Dr. Philip Hughes, 1526. Dr. Philip Hughes, 1526. Respiratory therapy, 1253. Respiratory
Hi,
therapy.
Mr. Nolan. Sarah's bringing your insulin. Mr. Brandon? Mr. Brandon?
Dr. Joanne Thomas.
Sarah, I need some help. Get the pillow out from behind you. Get your side rail down. Drop the head of his bed. Sarah, call a code.
Janet, call code 1153.
Help me with this backboard.
Code blue, 1153. Code blue, 1153.
You need to give me the Ambry with the oxygen.
How much oxygen do you want?
Last.
I need help. I can't get it. I can't get it. Get out of the way.
So let's move that down.
What happened?
I need a...
Let's get the monitor over here.
It's coming.
We need a line.
He's got one.
No, that's his tube feeding.
Where's the monitor? Turn it on. I need to take a look.
Don't have anything.
Yeah, he was doing so good yesterday. Let's get him intubated.
Need a laryngoscope. About number 82. It's been late.
He's in
Sarah, you want to
V-fib.
take over here?
Charge you 200.
Is it 7?
Give me what you got.
All right. All right.
Okay,
hand carry
charged,
change, sir.
clear.
Oh my God, my husband.
Mrs. Brandon, Mrs. Brandon,
no.
come down here.
Oh no.
Come down here.
No.
Still don't have a beat.
No pulse.
Do you want to go ahead
Ready.
and see?
Tell me when we're charged.
Ready.
Clear.
What you have just seen is perhaps the most emotionally charged, stressful situation you will face as a nurse, a cardiopulmonary arrest. It's life or death, unexpected, and usually chaotic. The patient needs your help immediately. But can you perform effectively? Do you know what your responsibilities are as a nurse? Do you anticipate the need for specific interventions during a code? That's the trick. Performing so that everyone involved knows what to do and works together as a team. It's not easy. The performance of technical skills isn't the only factor that determines the outcome in this kind of emergency. Emotional components also are likely to affect performance and how everyone reacts. You'll learn skills in this program that will help you recognize what's happening and anticipate what will happen next, whether or not you actually perform the intervention or make it possible for others to perform it. Let's take another look at the code you just saw, focusing on the inherent chaos that might affect your performance in the same emergency. A code is an unplanned, unscheduled event. It's an unwanted situation, and in most cases is unexpected, although sometimes you may have a gut feeling that something is about to happen. And you should also know which patients in your care are most at risk.
What's happened? He was just fine.
From the very beginning, you may feel defeated because despite your hard work with this patient and his family, he still may die. It wasn't supposed to happen. You may think you might have done something differently to avoid this situation, and you know the patient and his family counted on you. You may feel like you've let them down. These are normal feelings and responses, and despite your best nursing care, any of your patients may code. Try not to let these emotions get in your way. Respond to the code using all the skills you have learned and feel confident performing. Realize that when you first get to the patient, you don't know what to expect. Yes, it's uncomfortable, not knowing what to expect. It always is, no matter what the situation is. And because you don't know what to expect when you first reach the patient, you're not sure what to do. But there are certain steps and techniques you can always follow and perform whenever you are faced with a code. These will be discussed later in the program.
What happened?
I don't know.
Let's get the monitor over here.
It's coming.
We need a line.
He's got one.
No, sir, that's his tube feeding.
Where's the monitor? I need to see a rhythm.
Sarah, you want to take over
Let's
here?
get him intubated. Get the monitor hooked up. I need to see the rhythm.
The atmosphere during a code is chaotic partly because it's an emotional and demanding situation for everyone involved. And the professionals who respond to the code usually are not familiar with the patient and his health problems. Whoever knows the most about the patient should communicate that information to the code team. You may feel frustrated and frantic as everything happens at once, and you realize you have no time to lose. Now is not the time to be struggling in an overly crowded room to get needed equipment and supplies to the patient. You may also feel like you're not being effective if you're not doing something, anything, whether it's needed or not. Here you see a nurse picking up a piece of trash, an unnecessary action, yet she does not clean up the spilled water, which could be a safety hazard. Doing something that's really needed helps the situation. Doing something just to be doing it contributes to the chaos. Most hospitals have designated code teams who are expected to respond to all codes. As a team, they have the knowledge and skills that are essential in a code. As a nurse, your experience and skill level and your hospital's policies will determine the role and responsibilities you'll have during a code. Recognize that you can't do everything at once and set your priorities according to the established steps followed in every code. Maintaining seldom used skills is difficult. You may get rusty, or actually forget precisely how to do effective chest compressions, for example. That's why it's important to periodically update your knowledge base and practice these skills. Then you can approach and participate in any code with a degree of confidence in your ability to function effectively. Be prepared. The middle of a code is not the time to find that the crash cart was never restocked after the last code or that the equipment isn't working properly, both of which can contribute even more chaos to an already chaotic situation.
Where is it? All there is a number 7.
All I have is a 7.
Give me what you have. This light won't come on.
You may not be the person responsible for restocking the cart and checking the equipment on it, but someone on your unit should, and the task should be done routinely. Since you'll use certain drugs often during a code, know their location in the crash cart and have them ready for immediate use. For example, you're likely to use several doses of epinephrine, which is given both initially and at regular intervals throughout the code. Or you might anticipate a lidocaine or beryllium drip for use later in the code. Family members, other patients, and unnecessary people in the room during a code also contribute to the chaos.
Oh, my God, my husband.
Mrs. Brandon, come down here with me.
Every effort should be made to get them out of the room as quickly and kindly as possible.
A code is called for one of two reasons. Either the patient has stopped breathing, or the heart no longer is able to pump blood to the body's tissues. Regardless of which event occurs first, the other usually follows. This condition is known as cardiopulmonary arrest. Many conditions can lead to cardiopulmonary arrest, including ischemic heart disease, cardiac dysrhythmias, pulmonary embolism, respiratory insufficiency, aspiration, autonomic nervous system abnormalities, electrolyte abnormalities, acidosis, hypoxemia, tension pneumothorax, cardiac tamponade, and hypovolemia. The signs and symptoms of an impending cardiopulmonary arrest will vary depending on the precipitating condition, but recognizing hemodynamic instability is extremely important. Cool, clammy, pale skin, changes in level of consciousness, hypotension, and oliguria all indicate hemodynamic instability. In some patients, ischemic chest pain and certain dysrhythmias, such as third-degree heart block, multiple PVCs, and brief runs of ventricular tachycardia, may be signs and symptoms of an impending cardiopulmonary arrest. as may altered respiratory patterns and metabolic problems such as acidosis and hypercalcemia.
Mr. Gallagher, you're not sleeping.
Oh, I feel sort of funny.
Well, what do you mean?
Oh, I don't know, like something's about to happen. I just...
Mr. Gallagher? Mr. Gallagher?
Shake and shout. The first step taken whenever you suspect cardiopulmonary arrest. If the patient is unresponsive, open the airway and assess breathing. Use the chin lift head tilt maneuver unless inappropriate, then look, listen, and feel for evidence of breathing. Check the pulse. If breathing is not apparent and/or a pulse is not palpable, call a code.
Operator, code Blue Room 6304. Yes.
Immediately begin anticipating and prioritizing your actions based on the ABCs of all codes: airway, breathing, and circulation, the available equipment, and your skill level. You should know some of the basics, such as CPR. They apply to all code situations and can be initiated even before the code team arrives. Team members with various skill levels will be involved in implementing the ABCs, but you can and should get started immediately. Let's go back to the code we saw just beginning and focus on the ABCs of CPR. Airway access is mandatory. How you achieve this access depends on the equipment available and your skill level. To maintain airway access, use the chin lift head tilt maneuver and an oropharyngeal airway. Insert the airway into the mouth with the curved portion facing upward. As the airway is advanced toward the pharynx, rotate it into position. Be prepared to suction the posterior pharynx if needed. Either performing mouth-to-mouth or mouth-to-pocket mask breathing is the quickest method of ventilating the patient. The breathing rate should be 12 breaths per minute. But as soon as a bag valve mask device is available, use it to provide ventilation and supplemental 100% oxygen. Stand facing the top of the patient's head. Maintain the chin lift head tilt position and use one hand to place the mask over his nose and mouth. Place the last 2 or 3 fingers under the chin. Your thumb and other finger remain on the mask to ensure a tight seal. Compress the bag with your other hand and see if the patient's chest rises. If it does, lung inflation is being achieved. Maintain the breathing rate at 12 breaths per minute. Endotracheal intubation is the preferred method of airway management during a code because it isolates the airway and facilitates ventilation, oxygenation, and suctioning. But other interventions, such as defibrillation, may take place before intubation since bag valve mask ventilation effectively oxygenates and ventilates most patients. Intubation may also take place simultaneously with other interventions. Properly placed, an endotracheal tube allows full airway control, but only people skilled in intubation should attempt it. If you don't have the skills you need for intubation, you should anticipate the equipment needed for someone else to do it. Endotracheal tubes are available in various sizes. When selecting a tube, a good rule of thumb is size 7 to 8 for females and size 8 to 8.5 for males. Include the following equipment: the laryngoscope handle and blade, McGill forceps, water-soluble lubricant, tape, and a 10 cc syringe. A stylet may or may not be needed during insertion of the tube. Next, connect a pharyngeal rigid tip, or Yonker, suction catheter to a suction unit. Also have a tracheal suction catheter available. Then attach the laryngoscope blade to the handle and test the light. Assist during insertion of the tube as needed.
Stop bagging.
Would you like a salad?
Yes, please. Suction.
If the patient requires tracheal suctioning during or after the procedure, he should be hyperventilated to avoid hypoxemia. Firm backward pressure applied to the anterolateral aspect of the cricoid helps decrease the possibility of gastric distension and aspiration. It is maintained until the cuff is inflated and the correct tube position is verified. As soon as the tube is in place, it should be stabilized while the bag valve device is connected. Ventilation begins immediately while tube placement is checked.
Go ahead and resume compression.
Okay, I'll blow up the balloon then.
Okay.
Let me get some tape.
In good position.
If placement is satisfactory, the tube is taped and ventilation continues. Because ventilation now does not need to be synchronized with chest compressions, the ventilation rate is 12 to 15 breaths per minute. Hyperventilation is also recommended.
Margot, have they called the code?
Yes, they have.
Okay, we were talking and he just went out. I don't know what happened. There's rhythm. You bring me the ambu and
Your ambu.
if you could bring the board over, we'll...
Circulation is another of the basic steps. It is performed simultaneously with the other steps. Assess circulation by palpating for a carotid or femoral pulse.
get the board under him and then you can take over compressions.
All right. Are you ready?
1, 2, 3.
Okay, let me see if he's got a pulse.
No pulse, continue. Okay. Now, where are you supposed to code this, Margot?
I don't have any idea. We're still getting here.
If no pulse is palpable, if ventricular fibrillation or ventricular tachycardia is confirmed on the monitor, if a defibrillator is immediately available, and if you are authorized to perform defibrillation, that's the next step. If not, start chest compressions immediately to circulate blood to vital organs. Properly performed, chest compressions can produce a systolic blood pressure as high as 100 millimeters mercury. You would have done a precordial thump if the following was the case. You had witnessed and monitored the arrest, VFib or ventricular tachycardia was confirmed, and you could not palpate a pulse. If there was still no pulse and a defibrillator was immediately available, you would have administered electrical countershock before starting CPR. A code involves continual assessment, prioritization, and anticipation. Throughout the code, different team members will continue to assess the patient's status. Based on the assessment findings, priorities for treatment will be established. Once these priorities are established, you can anticipate what will be needed to implement treatment. Remember, you may not actually provide the treatment, but you're still a vital member of the team. It's not important who actually defibrillates or gives the IV medications, but it is important that you know what to expect next, what equipment is needed, and that you perform at your own skill level. When the crash cart and code team arrive, the first priority of care is to assess the heart rhythm, since the patient's ability to survive ventricular fibrillation or pulseless ventricular tachycardia depends on receiving electrical countershock as soon as possible. Many defibrillators are equipped with quick look paddles, which allow you to check the heart rhythm simply by placing them on the patient's chest. To use the paddles, apply enough conductive gel to prevent skin burns. Don't apply too much, though, because too much gel can also cause arcing and skin burns. You may also use gel pads. Place one paddle just to the right of the upper sternum below the right clavicle. Place the other paddle over the 4th or 5th intercostal space along the mid-axillary line. If ventricular tachycardia or ventricular fibrillation is confirmed on the monitor, electrical countershock should take place immediately. Current American Heart Association guidelines recommend 3 consecutive countershocks, taking time only to check the heart rhythm and pulse between each shock. The first shock should be 200 joules, the second 200 to 300 joules, and the third 360 joules. Safety precautions must be observed during defibrillation. A clear command must be given to let everyone know what is about to happen. No one should touch the patient or bed during defibrillation. Once the first shock has been delivered, the pulse and rhythm should be rechecked. Anticipate the need for a second shock if the rhythm has not converted and no pulse is present. Likewise, if the second shock is unsuccessful, anticipate a third. If a pulse is still not present, CPR will be resumed or started. The next priority is medications. If the patient already has an internal jugular or central venous line in place, use it for drug administration during the code. However, if IV access is not available, a peripheral line must be started. An antecubital vein should be cannulated with a large bore catheter as soon as possible. If the patient is intubated before IV access is available, some of the first-line code drugs, such as epinephrine, can be given via the endotracheal tube. The sequence of interventions will vary if the heart rhythm is electromechanical dissociation or asystole.
Electromechanical dissociation, or EMD, is the presence of electrical activity seen on the monitor without mechanical activity. No pulse is palpable. The intervention sequence usually followed when EMD is present is to continue CPR, establish an IV or endotracheal access route, and to give epinephrine IV push. Treat the underlying problem if possible. Consider giving IV push sodium bicarbonate. When asystole or cardiac standstill is the diagnosed heart rhythm, CPR should continue while an endotracheal or IV access route is established. Then epinephrine is given and repeated every 5 minutes. Atropine may also be given IV push. External pacing may follow if the epinephrine, atropine, or both fail to restore a heart rhythm. Sodium bicarbonate should also be considered.
Throughout the code, the patient's status and all interventions must be carefully documented. This information is especially helpful to review the timing of drug administration and during the post-resuscitation period. Another responsibility during a code is the patient's family members who require attention and emotional support. As you can see, Mr. Gallagher's wife and daughter are anxious and fearful about the outcome of the resuscitation efforts. The hospital clergy has been called in to help. The code team's responsibilities are many and varied during a code. Regular practice of your basic CPR skills and familiarity with the equipment used and the sequence of interventions is one way to increase your confidence and improve your performance in a code. Practice codes on your unit are also helpful. Let's review the important points discussed in this program. All patients in cardiopulmonary arrest, regardless of the setting, require CPR. CPR is the first and most important step toward successful resuscitation. Prompt early defibrillation is the most effective treatment for ventricular fibrillation and pulseless ventricular tachycardia. Airway control and the administration of 100% oxygen ensure adequate ventilation and oxygenation. An intravenous or endotracheal access route and the regular administration of medications help to restore effective circulation. A well-organized, well-coordinated team effort ensures that everyone is trying to achieve the same goal, successful resuscitation. Your performance as part of the code team can make a significant difference in the patient's outcome. You can ensure successful performance only by constantly reviewing the necessary skills and practicing with the equipment involved. You must always be prepared to meet the challenge a code represents.